Hello, this is Dr. Brown's Psych Commute episode 3. And today I think I will talk about electroconvulsive therapy or ECT in some detail. So, as someone who practices ECT on a regular basis at a pretty busy ECT service, I've got much to say about it. So, I guess let me start with a little history. ECT has been done for a very long time. It was discovered or invented, if you will, by an Italian, I believe, some kind of physician. I'm forgetting the name off the top of my head here, in 1938, and has been in clinical use pretty much ever since. Uh, ECT basically involves inducing a generalized tonic-clonic seizure under general anesthesia. So the patient is anesthetized, put to sleep. They're paralyzed. And once they're asleep and paralyzed, a small electrical current is passed through the brain, stimulating a seizure that generalizes to the whole brain. And the seizure may last anywhere from a few seconds to a minute typically, and it will self-terminate. And generally, we're using very short-acting anesthetics and paralytics, so they wear off quickly, and the patient wakes up, in 5 minutes or so, and that's it. So this has been studied for a very long time. There's studies on animal models. There's studies on post-mortem dissections of the brains of patients who have undergone many ECT treatments, looking for, how it works or any signs of side effects. And there has been no evidence of brain damage caused by ECT. And this is not a case of absence of evidence, means absence of effects. That people have looked hard, imaging studies, histology, and there's no evidence that ECT causes brain damage. One of the main side effects of ECT is causing memory impairment, both anterograde memory impairment, which is the difficulty of laying down new memories, and retrograde amnesia or memory impairment, which is the difficulty in recalling previously learned information. And I like to explain this to patients in the following way. I say that ECT, as far as we know, causes new brain connections to be formed, and that kind of crowds out the old connections. And so the way the treatment works, by creating new connections, it also causes the side effects. So much opposite to, causing a breakdown of neurons or damage to neurons, it's actually causing growth and rebuilding. And that inevitably has its side effects. What is ECT used for? It's used for depression, both unipolar and bipolar depression, exacerbations of schizophrenia. So ECT is not used for just the chronic symptoms of schizophrenia, but acute exacerbations. It could be used for schizoaffective disorder. It could be used for mania in bipolar 1 disorder, although that is often rare just because when people are manic, they're generally not very interested in doing something like ECT. And in most places, it's very difficult to do involuntary ECT. And then there's the use for catatonia. That is probably one of its most dramatic uses, and dramatic in the sense that it's most effective, I would argue, in that condition. And of course, catatonia is always secondary to something else. So those are the main things. Most of the time ECT is being used. It's being used for highly treatment-resistant depression. And in a prior episode, I talked about my qualms with the concept of treatment-resistant depression. But generally, somebody with a major depression, they're going to try a bunch of the typical medications first. And when that doesn't work, maybe they'll think about doing something like ECT. So the vast majority of the ECTs that I do are for depression, but we do a few of the others. I should also mention ECT is often particularly effective for, like I said, catatonic depression, but also psychotic depression. So if you do detect some psychotic features in a major depressive episode, that might be a reason to refer someone to ECT sooner than otherwise. ECT, it's a very safe procedure. One of the reasons I like it, I always tell my trainees that as a psychiatrist, we are physicians first and psychiatrists second. And so I think it's important to maintain our general medical skills. And for me, ECT is a good way to do that because in the ECT suite, you're paying attention to, the basic physiology closely. And when you pass this electrical stimulus through the brain, some of the current will activate some of the cranial nerves, like the trigeminal nerve and maybe even some branches of the vagus nerve. And what that often does is cause a parasympathetic discharge. So briefly, during the electrical stimulus delivery, you may get a bradycardia, and even in some cases, a brief run of asystole, which can be a little unnerving when you see it on the cardiac monitor. But generally, it's very short-lived because shortly after that, they will get a seizure, and the seizure causes a big sympathetic discharge. And so you will often see tachycardia and very high blood pressures. So I've seen some of the most impressive blood pressures that I've seen in the ECT suite. We're talking, 200s over 100s easily, 280 over, 140, something like that I've seen before. Heart rates into the, 160s, 180s sometimes. So you get a very strong sympathetic discharge. Generally, that is very transient. And, when you go on a vigorous run, you get a pretty big jump in your heart rate and blood pressure too. So our body can handle it for a few minutes for sure. Certainly in the elderly and folks with other kind of risk factors, or if this is happening, every single time, then generally we're going to pre-treat with something like labetalol, because labetalol is a alpha-1 antagonist and beta-1 and beta-2 antagonist. So it kind of covers the main clinically relevant adrenergic receptors. And again, this is a sympathetically mediated response. So it's really effective at tamping down that sympathetic response. Unfortunately, labetalol is also a little bit anti-seizure, and the whole point of ECT is to induce a seizure. So we have to kind of balance that. How it's anti-seizure is a little unclear. My guess would be because it's limiting cerebral perfusion, it just doesn't allow the metabolic delivery or activity that is required to sustain the seizure or get the seizure going. And so that's how it limits the seizure activity. It's not, as far as I know, directly anti-seizure in the way that, Depakote might be, where you have direct blockade of sodium channels and things like that on the neurons. But anyways, that's one of the potential complications that we pay attention to in ECT. Other complications include prolonged seizures. So people, like I said, a typical seizure is going to be over within about a minute on its own without us doing anything. But in some cases, for whatever reason, people can have prolonged seizures. And once the seizure is going beyond about 2 minutes, that's when we're starting to intervene. So I'll usually ask the anesthesiologist to give 2 milligrams of midazolam, which is Versed, and that's usually enough to abort the prolonged seizure. We might, if it's not doing anything within 30 seconds or so, we might give another round of 2 milligrams. And then very rarely does it go beyond that, in which case you're having to do maybe Keppra or something like that, getting more aggressive. You could also give a extra bolus of whatever anesthetic you're using, especially if it's something like propofol. And I'll talk a little bit more about anesthetics here in a moment. Another potential complication, somewhat related to prolonged seizures, is the possibility of a tardive seizure. Tardive meaning late. And I have seen this once in my practice so far, where someone, we did the ECT and they had a good seizure. We confirmed that it ended, and then they had another seizure after after the seizure had ended. And so we had to treat that, very similarly, giving Versed, midazolam, and so forth. That's very rare, and that's almost always due to there being an underlying structural abnormality in the brain. So in this case, the patient did have a history of a cerebral aneurysm and clipping. So the anesthetics that we use to put people to sleep, generally the first line is an old barbiturate called methohexatol, brand name Brevitol. The reason for that is, again, for ECT, we're needing to use very short-acting medications, things that are going to work quickly and stop working within a few minutes, because that's how short the procedure is generally. And Brevitol fits the bill for that. So, and we also don't want to use something that's very anti-seizure, because the whole point is to get a seizure. And methohexatol is among the least anti-seizure of the options. The other common option is propofol, which is very commonly used in anesthesia in general. And it's a great medicine for a lot of reasons. Again, quick on, quick off, generally pretty well tolerated, usually has a fairly smooth course to it, but it is pretty anti-seizure. So that is definitely not our first choice. But there are some cases where people seem to just have a low endogenous seizure threshold, and propofol can be a good option. Other potential options would be ketamine, although that's often used in combination with something like propofol. You could use a combination of propofol or methohexatol in an ultra short-acting opioid like remifentanil or alfentanil, and I have used that in the past with good success. And the reason for combining an ultra short-acting opioid is that it lets you get away with using less of the main anesthetic, which tends to be anti-seizure, and those short-acting opioids are not. And so if you're having a case of difficulty eliciting a seizure, you can use that and lower the anti-seizure load, if you will. Those would be the main things. We also use etomidate on occasion. Etomidate is pretty much not anti-seizure much at all, and so that's a great medicine, but it's associated with adrenal suppression and myoclonus, so it's definitely not the first choice. In terms of paralytics, once someone is off to sleep with something like propofol or methohexatol, then we're going to paralyze them. Typically, almost 99% of the time, it's going to be succinylcholine, again, because it's fast on, it's fast off, and it works. If someone has pseudocholinesterase deficiency, which is the enzyme, pseudocholinesterase is the enzyme that's responsible for breaking down something like succinylcholine. There are a few percentage of people out there who have a mutation or just a variant of that gene, and so they slowly break down succinylcholine, and so it can last, instead of a few minutes, potentially hours, which is potentially dangerous. So most of the time we do test for that. Although if you're in a big hospital with an ICU and things like that, it's maybe not routine to test for that, because the worst case, you just ventilate them longer than you need to. The other main option that I've used in ECT is rocuronium, which is a fairly long-acting molecule, but it has a reversal agent called sugammadex, which is really cool. I recommend you look it up on Wikipedia. It's a really interesting looking molecule. But by using the reversal agent, we can sort of turn off the paralysis pretty quickly. So in that regard, it works well for ECT. But yeah, most of the time we're using succinylcholine. It's cheap. It's been around a long time. Rocuronium is also inexpensive, but sugammadex is not. Before sugammadex was invented, you could reverse it with a cholinesterase inhibitor like physostigmine or something like that. But then you can potentially get side effects from acetylcholine excess. So that's not ideal. Those are there's a lot more to say about ECT, but I have arrived at work, so I will end it there and maybe finish this in a part 2.